welcome to the Post-COVID Future of Heart Disease Prevention webinar. I'm Katherine Wilemon, the founder and CEO of the Familial Hypercholesterolemia Foundation. If I haven't had the opportunity to meet you, just to let you know, I have familial hypercholesterolemia and high Lp(a), and I'm so glad that all of you made the time to join us this evening. So let's go to the next slide. So just a disclaimer, we're so lucky to have Dr. Larry Sperling with us this evening, but none of the information that he or myself will be sharing should be construed as medical advice, diagnosis, or treatment. And if you have further questions, please ask your doctor or go to the CDC website. So I think we've covered this. Say hello, use the chat function. We all need to connect a little bit. So it's so nice to see so many people that we know. And I see Jerry's in Florida where it's 80 degrees. I'm in Florida now, and it is nice and balmy. And we're thinking of our friends who are not so warm elsewhere in the US. So when we go to the question and answer function, you can be putting your questions in as Dr. Sperling is making his presentation, but please switch over to the question and answer function. I'd like to thank our sponsors for their support of the FH community in action, as well as the Lp(a) community in action. I'd like to especially mention Amgen and our premier sponsor, Sperling, as well as all of the families who support the work that the FH Foundation does. Thank you. You make our work possible. So one of the things that the FH Foundation has been doing over the last year is trying to help individuals either with high Lp(a) or familial hypercholesterolemia navigate this new world while we are all living through a global pandemic. You can go to our website and you'll see some webinars at the very beginning of the pandemic. We were trying to get out as much information as possible, as well as blogs. And I think it's important to note for those of you who have FH or high Lp(a) that there are also materials that you can download in case you were to become sick or ill with COVID, that you could take them to the ER or to another doctor and say, this is my history, this is why I might be at greater risk. So you can go onto the FH Foundation website and download those materials and fill in your health history. Go to the next slide. We also hope that you will join us in our work and in our community, that you will share the resources that the FH Foundation has put together with your family and friends and with your clinicians, and that you'll join our online support groups, as well as share your story. You can go to the website you see listed here to share your own story of living with FH or high Lp(a), volunteer, or make a donation. And so now it is my great pleasure to introduce to all of you Dr. Larry Sperling, who is the founder of the Preventive Cardiology Clinic at Emory University and a Katz Professor in Preventive Cardiology. He's known all over the world and really is a dedicated clinician scientist. And we're so pleased, Dr. Sperling, to have you with us this evening. So I'll hand it over to you, and then we'll do question and answers after your presentation.
Well, first of all, really sincere thanks for the opportunity to join all of you today here. Very familiar with the FH Foundation. In fact, I've been working with the FH Foundation since its start, and pleased to be a resource to all of you. I specifically chose the title, The Post-COVID Future of Cardiovascular Disease Prevention, because I want to emphasize that there will be a post-COVID future. And hopefully the lessons we learn in the midst of this pandemic will enhance our focus and approaches to cardiovascular care and cardiovascular prevention. As Katherine had mentioned, I founded one of the first cardiovascular disease prevention programs in the country at Emory, and have cared for numerous patients over the years living with FH and elevated Lp(a), and so I do understand the concerns and questions from this community, and I look forward to addressing your questions at the end of the presentation. There we go. So importantly, I have no conflicts related to my presentation today. As was mentioned, certainly I will be sharing important information, but this is not information that you should use to directly focus on your own clinical care. And so if you do have questions and concerns, address these with your clinical team. I am a preventive cardiologist. I have dedicated many years to the work that I do. My only disclosure is I am not an absolute expert on COVID, but all of us are learning and adapting. So before we get to the post-COVID future of cardiovascular disease prevention, because I do want to talk about lessons learned and where I hope we will be, I'd like to touch first upon the past very briefly, spend a good amount of time talking about our present COVID future, and then leave you with what I hope will be a brighter future. When I refer to the past, I will emphasize BC, before COVID, and there was a before COVID. When Franklin Delano Roosevelt dedicated the National Institutes of Health, and it's called the National Institutes of Health and not the National Institutes of Disease in 1940, he said we cannot be a strong nation unless we are a healthy nation. I've had the privilege to work with the World Heart Federation, and I still work with them on global cardiovascular disease prevention. And two of the former presidents have impacted my career greatly. Salim Youssef said back in 2013 at a meeting in Rome that cardiovascular disease is the biggest epidemic or pandemic ever known to mankind. And we need strategies to address epidemics. Valentin Fuster, a former WHF president, he's now the editor of JACC, the Journal of the American College of Cardiology, said secondary heart disease prevention is urgent. As you look at this slide here on the left-hand panel, you see a photo, and this photo looks quite familiar to our current situation. Individuals wearing masks, and what gives away that this photo is not in 2021 is that it's in black and white and people wearing these broad brimmed hats. On the right-hand side, you can see this was from the Spanish influenza pandemic back in 1918, where there was public notice about the importance of isolating from public places and the importance of limiting public gatherings. Now, as we finish up on a little bit about the past, all of you have recognized that our worlds have dramatically changed over the past year. As we come around the corner to where it's been a year since the public health emergency was announced in this country, March the 18th, 2020, we recognize that our usual is not so usual anymore. And these are two photos of myself, one of our preventive cardiology fellows. On the left is a photo taken in Florida at one of the former FH summits, and on the right in Dallas. And just to acknowledge the amazing work that the FH Foundation does and continues to do. And Katherine Wilemon is really one of my heroes. And I know she's doing amazing work with the foundation. So we've talked a little bit about the past. Now I want to spend a significant time talking about our present, our COVID-related present. And as I thought about this presentation, there are many COVID-related realities. First of all, that we've been adapting almost daily, that our knowledge base remains, even after a year, quite uncertain. And we still have many unanswered questions. And when we field your questions at the end of the webinar, I will do my very best to answer these questions, but realize that we do not have all the science. or evidence to be confident in the answers to these questions. So we're learning on the fly, and at this time, I'll be able to share what we know. We are certainly making decisions every day about risk, but also focusing on risk mitigation. The 3 W's: washing our hands, watching our distance, and wearing masks. There are various signs and symptoms of COVID-related illness, as you are likely aware. There are treatments that have been developed and are now in development. And thankfully, we have a COVID vaccine program, available vaccines, vaccine strategy in progress, and several vaccines that hopefully will be approved in terms of the public health emergency in the near future. And right now, trying to get a better understanding of the COVID variants that are transmittable around the world and are now making their way to the United States. Several slides to share here. First, just thinking about the severity of COVID-related illness. Many individuals with COVID are asymptomatic or are minimally symptomatic, and that's been one of the challenges in terms of mitigating this epidemic. Many people, though, still have mild disease, but there are individuals that get quite ill, requiring hospitalization. And many who require hospitalization are in need of critical services. COVID can affect really the entire body, and it can affect the heart, as I'll speak about shortly. There's an immune response that occurs to this viral illness, and what can happen is, as with other viral illnesses, there can be effects on our body, at the level of our lungs, but also across all of the organ systems. The relationship between COVID and the heart is a bidirectional one, meaning that COVID itself, the virus, and then the response to the virus, the immune response, can affect the heart in many different ways. It can affect the heart in terms of stress or injury, causing a heart attack, both in the traditional way of causing an artery plaque to rupture, but also a heart attack related to stress of the heart. It can cause inflammation of the heart muscle. It can cause heart rhythm problems, increased risk of clotting at the levels of our arteries and veins, and even clotting in the small blood vessels. And then we do know that individuals living with cardiovascular disease and cardiovascular disease risk do appear to be at increased risk of COVID-related illness. Well, I talked about adaptation. A few of the slides that I've incorporated into the presentation today, I made this morning because these papers were just published this week. And this is a paper published this week in the American Journal of Preventive Cardiology, looking at our national population through the National Health and Nutritional Survey and extrapolating data to the adult Americans. And this paper looked at risk for severe or significant COVID-related illness if you're over age 65 and you have at least one of 10 chronic medical conditions that predispose to severe illness from COVID. And the paper highlighted that at least 70% or more of adults in our country have at least one of these conditions, and almost 70% of those even under the age of 65. We see greater risk in those with lower education and income. And then just to reinforce that we have 6 million or more Americans living with heart disease. Just to point out these 10 conditions, so above the age of 65, and these 10 chronic medical conditions: current cancer, COPD or chronic lung disease, chronic kidney disease, immunocompromised status from an organ transplant, obese by definition with a BMI greater than 30, serious heart conditions, a history of heart failure, overt coronary artery disease, like a heart attack, a stent, a bypass surgery, cardiomyopathy or weak heart muscles, sickle cell disease, current or past smoking, pregnancy, and type 2 diabetes. Well, how do we think about approaching our COVID world right now? This is a nice 2x2 table looking at whether you have no prior heart disease, whether you're COVID negative or COVID positive. And in the center talks about considerations for healthcare workers. For the general population, we talked about the 3 W's, those mitigation factors that we should all be following on a public health level. If you are COVID positive, even with no prior heart disease, you should be aware of the symptoms and possible sequelae of COVID that can affect the heart. With no prior heart disease, if you're COVID negative, you should be taking the appropriate steps to focus on your safety and health. I do want to mention that this is American Heart Month, and so wishing all of you both a safe and a healthy American Heart Month. Many of you have been in the world of telemedicine now, a new way of encountering your clinical team. And then also thinking about risk, especially as it relates to elective procedures, and then wearing masks when you're in public places. This again is from a paper that was just published this week in the Journal of the American College of Cardiology. And I think this central illustration is really useful. On the left-hand side of the panel, it talks about the puzzle of potential consideration of risk as we think about vaccination of COVID, vaccination for COVID, realizing that there's a spectrum of risk that involves our age, our underlying health conditions, our exposure risk. So if we are essential workers and we're still out in the general populace, accessibility to healthcare, and then at-risk factors that may relate to social, cultural, ethnic, and socio-demographic factors. On the right-hand side here, if you start at the bottom looking at cardiovascular clinical risk for severe COVID-19 outcomes, you see at the bottom are heart risk factors like being overweight, having high blood pressure, having diabetes, but not treated with insulin. And then as you go up this grid here, it looks at various levels of risk. And at the top of this grid are those who are quite ill, living with various forms of heart disease, recent hospitalization for heart disease or heart failure, pulmonary hypertension, adult congenital heart disease, peripheral arterial disease, those with morbid obesity, and multiple cardiovascular risk factors, including diabetes. Now, you see nowhere on this grid is hypercholesterolemia or familial hypercholesterolemia or elevated lipoprotein little a. And that's because we really don't have the data to say whether alone these isolated risk factors increase COVID-related risk or risk for COVID-related illness. So there's a spectrum of risk. We have many unanswered questions, and we still need to learn about populations of potential concern. This is from the national ongoing COVID and the Heart database housed with the American Heart Association. And this was presented at the American Heart Association back in November. Back in November, there were over 23,000 patients from over 100 US hospitals as part of this registry and database in progress. Out of these patients, about 9% of them had in-hospital heart-related complications. Heart rhythm problems like atrial fibrillation, 3% with a heart attack, myocardial infarction, about 4% with blood clots in the legs or lungs, a DVT or PE, and 0.3% with inflammation of the heart muscle called myocarditis. The majority of these patients had heart-related risk factors, high blood pressure, diabetes, obesity, and 10% of the COVID-related deaths had some cardiac-related causes. There were greater proportions of individuals who suffered cardiac events who were Hispanic in origin or non-Hispanic Blacks. This is from an interesting paper, and I do think this is an important thing to pay attention to, because as we think about who are the younger people that are ending up in the hospital and with hospital-related severe illness, a small portion of the young have a severe inflammatory reaction secondarily to the virus, but the other young that are being hospitalized with more severe illness likely have increased cardiometabolic risk. And this is a combination of obesity and other risk factors like high blood pressure, prediabetes, or diabetes. I know many of you have heard about the concept of long COVID or the long haulers. This is another area where we still have a lot to learn. This was an initial paper published from Italy, 140 individuals recovering for COVID, and they looked at these individuals 2 months after their hospitalization, and only 13% were symptom-free. So 2 months after their hospitalization, many still were experiencing symptoms of fatigue, shortness of breath, chest pain, and heart palpitations. For your awareness, just to be familiar with ongoing collaborative cohorts that are occurring across the country through the National Institutes of Health and other bodies, looking at some of these unanswered questions, the major determinants of severe COVID infection, the health disparities across the general population, the potential long-term sequelae or complications of COVID infection and COVID-related illness. And then a really important question, how has this pandemic altered health and disease among our American population, both with and without COVID? This was the front page of the New York Times from April the 25th, and it's kind of hard to believe that April was, so long ago now, because this adventure has really been one day at a time. And on the front page, the headline was, "Amid the coronavirus crisis, heart and stroke patients go missing." And what we know now is that these patients were not missing, but where they were missing from were hospitals and health systems. From 2 MMWRs, morbidity, mortality, and weekly reports, you can see here on the left-hand side that in the 10 weeks after the public health emergency declaration, in hospitals across the country, there was a significant drop in patients presenting with heart attacks by 20%, strokes by 20%, uncontrolled high blood sugar by 10%. On the right-hand side is another MMWR publication that highlighted those at increased risk. Those with heart disease, diabetes, and lung disease had a 6 times greater rate of being hospitalized and a 12 times greater rate of dying of COVID-related conditions. One of the take-home points today is the importance of keeping up with your regular care, your regular medications, your regular care team, and your regular focus on lifestyle and behavioral efforts and general cardiovascular disease prevention. From another MMWR, this pointed out, this was back in September, that 4 out of every 10 US adults were delaying or avoiding their medical care, both urgent care and routine care. And this was seen even at a greater level in those who had multiple medical conditions. So as we are messaging from the world of healthcare, it's important to realize that precautions and protocols are being taken to provide safe environments for your care as needed. Now, what we don't know is the long-term consequences and unintended consequences of this COVID pandemic. The first curve here from this paper in Circulation back in July was the curve of acute COVID infection. The second, the delay in urgent care and lack of what we call guideline-based care. Second, waves of infection, but also the neglect of chronic conditions. And then we know through social isolation and the impact on COVID on our society and mental health and our economic health that we may see the consequences of this pandemic lasting beyond the current year and years, but potentially decades. Well, what is the advice that we should be giving to our patients? And if we flip it in the reverse, this is the advice you should be embracing for yourself. Don't defer your visits. Keep up with your health care. If need be, use telehealth or telemedicine. At each visit, share any new symptoms or concerns with your clinical team. If there is an emergency, if you're having symptoms of an acute heart attack or stroke, these are medical emergencies, and you shouldn't delay. You really want to be seen at your closest hospital or health system because time can be the difference between life and death. The safety issue is the protocols and procedures are being taken for your safe care. Make sure you have all of your typical medicines and a significant number of refills available. Take good care of yourself, your physical activity, nutrition, and then also take good care of your mental health, focusing on the importance of social support. And although we are stressing the importance of watching your distance, you really want to be connecting to those that you care for and care about more than ever. We've also recognized the importance of utilizing the full care team. So here we are in the COVID-related present, where I believe that cardiovascular health prevention and cardiovascular care must remain a priority more than ever. This is a little bit of BC data before COVID. And what we can see here is that in our country, between 1950 and about 2010, we celebrated the reduction in the rates of death from heart attack and stroke. But we also need to realize that heart disease has been the leading cause of death in our country since 1910, with the exception of the flu pandemic years, and that racial and ethnic disparities persist related to cardiovascular disease mortality, and they have for many decades. What happened BC though, starting at about 2010, these rates of decline flattened out, and then they started to increase even before the pandemic. And the question is, where will they lie in the current year and the years to follow? I've shown this slide all over the world just to point out that although we talk a lot about our genetic code, that where we live in our country, our zip code is a more potent predictor of health and disease. And so health varies at a very local level. This is a slide of Atlanta where I live. And if you live in the north part of the city in Buckhead versus Southwest Atlanta, just a 15-mile difference, there's a 13-year difference in life expectancy. We come back to the question of preparedness. And unfortunately, as a nation, we are quite unhealthy. And so we were not adequately prepared for a viral pandemic. We can see this data here from over 350,000 Americans, a behavioral risk factor and surveillance survey, that only 3% of Americans have ideal cardiovascular health, and about 10% of Americans have poor cardiovascular health with disparities by age, gender, education, and ethnicity. This is a figure from the American College of Cardiology's National Cardiac Data Registry, looking at over 2 million patients cared for by cardiologists for groups that should be receiving statins for heart disease prevention, those living with heart disease, diabetes, LDL cholesterol above 190. So those with severe hypercholesterolemia or possible FH, familial hypercholesterolemia, and a 10-year event predicted risk above 7.5%. And in this population, 25 to 35% of these patients were not even receiving statins. From a former US Surgeon General, C. Everett Koop, he said back in 1985 that drugs don't work in patients who don't take them. I talked a little bit about BC before COVID, spent a good amount of time related to our COVID-related present situation. And now what I want to leave you with before we have some time for discussion and Q&A is my sense of what I hope will be a post-pandemic future focused more on heart disease prevention. A lot of this was spurred on by a chat site from the American Society for Preventive Cardiology. One of the fellows in Canada posed the question about the future of preventive cardiology. This was back in March when there were only 508 deaths in our country and 42,000 cases. I looked up this data yesterday, and as you can see, we now have in our country almost 29 million cases of COVID, 490,000 deaths. But as I pointed out earlier, thankfully, we have vaccinations that have been developed that are quite effective related to this virus. And so you can get a snapshot every day of COVID-related illness across the country and the world, but also in our country, what's happening with COVID vaccination. At this point in time, over 55 million Americans have received their COVID vaccination. So that's good news. I wrote 2 commentaries that were published related to this question about the post-COVID future of heart disease prevention. And this was a quote from one of them: "The risk for COVID-related morbidity is driven by an interaction of this viral illness and an unwell population. And so we will need to invest more than ever in essential services like heart disease prevention, population health initiatives, and public health." And in another commentary about this cardiometabolic risk, the risk and intersection between heart disease risk for diabetes needs to be a priority, and that the lessons learned during the pandemic recovery will be critical to ensure the health of our population going forward. I've used this quote very frequently over the past year. It's an Albert Einstein quote, and I think it's one we need to take to heart. In the midst of difficulty lies opportunity. And our opportunity is that the future of cardiovascular medicine will be and has to be a greater focus on cardiovascular health and cardiovascular prevention. This is a figure from a paper we published several years ago, which looked at the heart health disease continuum. On the right-hand side of this slide in red is late heart disease. But our paper stressed the importance of a better understanding of what it means to be heart healthy, to focus on heart disease prevention and health promotion. We've seen with this pandemic the unmasking of many vulnerabilities across the population. And one of the vulnerabilities is related to social determinants of health and health disparities. On the left-hand side of this slide, you can see that we need to think very differently as we address these social determinants of health: access to care, healthy foods, psychosocial, behavioral, and environmental factors. From a clinical standpoint, one of our challenges, and I hope we will do better here, is what we call therapeutic inertia. We really want engaged and partnered individuals to help really better their own care. So I know those working with the FH Foundation tend to be very proactive with their clinical teams, but it's important that you focus on partnered care. And then also there are many systems-based approaches which may improve optimization of care as well as prevention. Well, what might the post-COVID future look like, and what will I hope it will look like? I think we'll see acceleration of new care models. We're seeing this happen right before our eyes. Greater use of telehealth and telemedicine, a decreased use of ineffective low-value care, so we can focus on proven and effective high-value care. In the future, hopefully a greater what we call volume to value transformation. And we are seeing a greater movement to further healthcare integration and consolidation. We come back to the question that was raised by one of the former presidents of the World Heart Federation, Salim Youssef, about cardiovascular disease really being a global epidemic or pandemic. And the way we need to address epidemics and pandemics is very specific. We need to identify their vectors, their causes, Then we need to think about barriers and roadblocks and factors that propagate epidemics, which is some of the work we have in progress right now related to COVID and the intersection between COVID and an unwell population living with many chronic diseases. But ultimately, with pandemics or epidemics, our goals are control, and then they are elimination and ultimately eradication. So I've given you a tour of the past, certainly the present, a little bit of a sense of where I hope we will be related to the future as we've learned important lessons real time during this global pandemic. As we think about the post-COVID future of cardiovascular disease prevention, we need to recognize that COVID is impacting the heart-related care, heart disease prevention, and cardiovascular care in general in our country and across the world, as well as heart-related outcomes. Heart health and prevention remain a priority, and they need to be a priority more than ever in the midst of this pandemic. And that in the future, there will be a greater need for the integration of healthcare with public health at the level of the community. I'm originally from New York, so I'm going to end with two quotes. The first is a Yogiism. Yogi Berra was the former catcher of the New York Yankees, and Yogi said it's tough to make predictions, especially about the future. And then William Shakespeare highlighted that it is not in the stars to hold our destiny, but in ourselves. Each and every one of us can contribute right now to the efforts related to this pandemic, focusing on our own care, our families, and the health and well-being of our communities. By working together, I hope we will be moving forward and continue to move forward as we move out of this pandemic into the post-pandemic and post-COVID future. So with that, again, I want to thank the FH Foundation for the invitation and the opportunity to join all of you today. I think I'm right on time because I was told 7:40, which should be my the end of my presentation, which will leave us with a good bit of time for dialogue, questions, and comments. So I thank you all again.
Thank you, Larry, so much for that excellent presentation. I really think that your perspective about the intersection of public health and personal responsibility is good for all of us to think about and hear. I think that for many in our community, they feel a sense of double vulnerability because, as you said, we are dealing with a pandemic in which new information is being ascertained on a weekly basis. And at the same time, people feel that within the medical community, their condition is often poorly understood. And so I think there's a little bit of anxiety within our community about how that will work for them. And it's part of the reason, for example, that we put together those letters that people could print out, because we've all experienced, those of us with FH, going into a medical care facility and having someone say, familial hypercholesterolemia, what? And so most of the questions that we're getting reflect some concern about how people should navigate their own care in terms of both the vaccine and their treatments when it comes to COVID. What should people delay taking the vaccine or delay taking their PCSK9 inhibitor injection? We hear a lot of questions on Facebook, and we're seeing some of them live today. So maybe, I know you said it's incredibly important that we all continue to take our medications, but if we could just get a little bit more granular for this population about the importance of continuing medications and whether or not there is any concern, and then shift to vaccines as well.
Yeah, so thank you, Katherine. And these are very important questions. And I completely understand the uncertainties and the anxiety. And we all have, uncertainty and anxiety every single day. As far as thinking about care in general, I'm a very big proponent of partnered care. So be active with your care, be proactive with your care, and stay in touch with your care teams. Certainly, it's helpful to have very specific questions to provide to your care team and your clinicians. And those specific questions right now are frequently related to risk. That was one of your first questions, Katherine, on behalf of this community, risk. In general, we want to be aware of our cardiovascular risk, even when there's not a pandemic, whether we have heart disease or don't have heart disease. But now, an important question for your clinician is, first of all, if you don't have heart disease, it's still an important question. Am I at risk for heart disease or other chronic conditions? Because prevention and well care still remains extremely important, but related specifically to COVID-related illness. And as you can imagine, I've been asked this question numerous times by my patients, my friends, my family, my neighbors, because everybody has this question. Am I at risk if I develop COVID? And some of the slides I showed, I think, help. And it's a spectrum of risk. I say that, unfortunately, one of the uncertainties is that every single human being is at some risk of COVID-related illness. So whether you're 10 years old or 100 years old, there's a lot of uncertainty, because I do think ultimately we'll see what's probably a gene environment behavior interaction related to this interaction between the virus and our community and then individual hosts. So I don't think anybody's entirely safe, even if you're young and healthy. But the spectrum of risk involves age, and then it starts involving whether you have medical conditions and medical risk. Now, on the high end of the spectrum is if you have severe chronic conditions and you've been recently in the hospital or you're immunocompromised, you're probably at the highest level of risk. And everybody should be taking precautions, but those people, really should be taking the highest level of precautions not to get COVID. Related to those living with FH and elevated LP(a), each and every one of you is unique. And so I couldn't make a blanket statement that FH, because it's living with FH and all the other things that come with you as a unique individual. Where do you live? Your family situation, what kind of work do you do? Do you have other health conditions, including maybe a known heart disease? Similarly with LP(a). And so right now, I couldn't make a very definitive comment except, you should think about your individual risk, discuss this with your clinical team, and think about this as it relates to you and your family, but especially as it relates to yourself, preventing getting COVID and preventing getting COVID-related severe illness. And then the intersection between COVID and other chronic diseases. As it relates to your medications, and you can interrupt if you want to ask some intertwining questions, but absolutely keep up with all your regular medications. There's no evidence that any specific medication is deleterious right now related to COVID, especially your blood pressure medicines, your cholesterol medicines, your diabetes medicines. Timing of medicines that are unique is a great question, like a PCSK9 inhibitor or LDL apheresis. I started the first LDL apheresis program in Georgia 20 years ago. And here, I don't think we have any evidence that there's any interaction between these therapies and risk for COVID and or attenuating or reducing the effectiveness of COVID-related vaccination. However, as you've heard, you can have COVID vaccine-related side effects. And although they're uncommon, because usually if you do have them, they're very mild. And I'll tell you, it's a little pain at this. I've already had both of mine. So a little pain at your vaccine site is the most common. Maybe feeling slightly tired. But because these possible side effects are unpredictable, and you can feel, ill, or like you have, chills or even fevers. I might try to time the PCSK9 inhibitor or LDL apheresis for that reason, giving yourself a little bit of a buffer from the COVID vaccination. I'll stop right there because I'm doing a lot of talking. If you want to add some other questions, I saw Kat asked about other therapies besides remdesivir, but I'll stop for a moment and see if you have a specific question.
Well, I just want to say that we did receive a question from our community about apheresis specifically, and I think that you answered that. But what, in terms of timing and getting the vaccine, and whether or not someone should be concerned that if they got the vaccine and then they immediately had apheresis, would it possibly clean out or filter out the potent agents in the vaccine? And we actually reached out to Konica and they said they didn't think so, but I think that it could be conservative. As you said, you could wait a week, but that's not delaying care in any significant manner.
I would say, having worked in the space of LDL apheresis now for 2 decades, there's no scientific evidence that you would think that LDL apheresis would reduce the effectiveness of the vaccine. If you had to make a choice though, realizing that your LDL apheresis team likely would be generous to say, if you said, hey, I have an amazing opportunity to get a COVID vaccine on day X, leap at that opportunity, because the effectiveness of these mRNA vaccines is very impressive. Yes, there can be side effects, but most of them are very mild. And so in the balance of benefits versus risks and side effects, there's no question you should get a COVID vaccine. And of course, we still have lots of unanswered questions about the vaccine itself. Will it be good for the rest of your life, or will you need additional boosters? And there are COVID variants. But I would say go with the vaccine. Tell your LDL apheresis team to reschedule you either for a few days later, just to give you that buffer, or for the following week. And it's unlikely by delaying your LDL apheresis 2 days or a week that that would have significant impact upon you.
And similarly, if anyone had any concern about PCSK9 inhibitors, which I know there's no evidence that they should prioritize getting the vaccine and then continue roughly in the same time frame with their PCSK9 inhibitor injection.
Yeah, I'd say, again, there may not be as much flexibility with your vaccine time and place, although, if you're signing up for the vaccine, because many people will sign up for a vaccine on a website, for instance. Well, then if you're due for your PCSK9 inhibitor injection on a day that you have on your calendar, purposefully time the vaccine to be a buffer on, either side of that, for instance. But if you didn't have a choice, I say get your vaccine and, just shift your PCSK9 inhibitor a few days, and then just come back to your usual regimen.
So I will just comment on whether or not we have any data about the FH population being at higher risk for poor outcomes if they do contract COVID. And we're seeing in our large healthcare encounter database, Larry, that we have about data on about 300 million Americans. That's very robust and includes lab data. We have seen some signals, and we've actually submitted a manuscript. So we'll see, it'll go under peer review, and hopefully that will be published. But as you said, it's very individual, and it's really the totality of any single individual's risk factors, plus perhaps their exposure to the virus itself.
Yeah, I think that's an important point. Even when there's not a pandemic, you want your arteries and the rest of you to be as healthy as possible. but this is a really important time to focus on your health. And if we thought about it scientifically, if you had FH, for instance, without known heart disease, and your cholesterol was not being optimally treated, well, then if you had some silent plaque in your vessels and you developed a viral illness, that viral illness, whether it be COVID or another viral illness, but certainly COVID, could stir up that plaque and put you at higher risk. So all the more reason to focus on the public health efforts for prevention, all the more reason to focus on your individual health and the health of your family and your community. And then all the more reason to focus on getting a vaccine, and let's get some herd immunity going.
So I want to make sure we have time also to talk about treatments, because I think it's very interesting that, as you say, the focus should be and is on prevention. The personal things that we can do that we know now from the data really make a difference, like masking and washing your hands and keeping your distance. I mean, they sound so simple, but they really work in terms of protecting ourselves and others. But if someone does contract the virus, could you just speak briefly, especially for, as we talk today, to a higher, in general, higher risk population, about whether or not people should quickly go and look at the possibility of treatments and the issue of timing, because I think that's critical, and I don't hear as much about it in the general public, the conversation.
Yeah, one of the slides I showed talked a little bit about the spectrum of illness. So still many people with COVID-related illness are asymptomatic or minimally symptomatic, even if they're older or have other health conditions. And this is where, all these questions and uncertainties are there. So why does one 80-year-old person end up, having a little bit of a runny nose and a slight muscle ache, and then another person ends up in the hospital severely ill? And so I don't think we fully understand this. I do think there's going to end up being various genetic predispositions in terms of viral susceptibility, but also a genetic predisposition to have a more active immune response to the virus. But if you did contract COVID, the first thing I would do is contact your clinician, have a conversation with them, let them know how you're feeling, emphasize to them about your general risk profile. Remind them that you do have FH or high Lp(a), or you do have a history of heart disease, or that you were just in the hospital just 3 months ago. They might not have remembered that. So have that conversation. Then you start the monitoring. I certainly wouldn't, if you're asymptomatic or minimally symptomatic, I wouldn't, leap to seek in-person medical care. For some people, it's useful if you could obtain a pulse oximeter, because even if you're asymptomatic or you're starting to develop some shortness of breath and your oxygen saturation levels in the blood were dropping, below probably about 94 to 92%, that would be another reason to connect back with your clinical team. But if you do need to seek care, there are therapies that can be beneficial. An antiviral agent, remdesivir, steroids. For some people now, giving what are called monoclonal antibodies. These monoclonal antibodies are very specific to the COVID spike protein. And so if you are starting to get ill and you are somebody of greater age with significant health conditions, there is evidence this can help you. And then there are other therapies that are available that are very specific antibodies to the immune response that some people have. So we don't have a cure, but we do have therapies that can help reduce the chances of severe hospital-related illness and death.
Great. Well, I mean, we're so lucky to live in a time where science is working as well as it is, and that the scientific community has united to bring about all of these therapies. I know that all of us are weary of being more isolated and having to change our lives as much as we have. But I also, when we reflect back on the last great pandemic, I mean, we are so lucky that we have as many options as we do, and we understand what we can do to potentially prevent it as well as treat it. It leaves us all feeling somewhat vulnerable, but I do think that we live in a great time to celebrate science and medicine.
Yeah, I agree. I think we need to be grateful. We certainly need to recognize the the priorities we have in life right now, and it really points out what's important to us. So be grateful, recognize what's important in life, and then I think we need to have hope. We should have hope, because there are many people working extremely hard uh, on all fronts to combat our current situation and this pandemic, and recognize that I hope there will be a post-COVID future. I hope we'll end up in a better place on the other side of all of this, and that's why I said, thinking about the post-COVID future of cardiovascular disease prevention, we really want to embrace these opportunities. And I do think in the future we will continue to have really amazing and inspiring opportunities to treat those living with FH, and excitingly for those living with elevated Lp(a). It's really, I mean, I see miracles happening every day. So be optimistic. I know that's hard in the middle of our current situation. Be hopeful, but be supportive. Be a really important and engaged member of your community to reach out to others right now. Even if it's just to reach out and ask how people are doing, how are they feeling, because it's a time that we also need to listen and learn, and be supportive, and we hopefully together will move forward.
Well, Larry, you are certainly an incredible clinician, but also you are one of the kindest um, people I know, and you've always been very generous to me and to the work that the FH Foundation does in the community. And I just want to thank you. You're quite a busy person, and for carving out the time to speak to the community this evening. We genuinely appreciate it, and thank you for everything that you're doing on our behalf.
Well, thank you all. And again, really appreciate the chance to visit with you this evening.
Thank you. Me too. Everyone be well.